Good afternoon, and thanks for joining us for today's Healthline. I'm Courtney Butts, your host, and Healthline is where we like to focus on ways to live a healthier, happier, and pain-free life. We'll be taking your calls and answering those questions that you have live in the studio today. We'll be opening those phone lines soon, but as a reminder, please make sure you're in a quiet room when you call with your TV turned all the way down so we can hear your question. That number to call is 318-219-4569, and today's topic is all about diagnosis and treatment of urologic cancers. Joining me to talk about this subject is Dr. Tom Siskron with Willis Knighton Signature Urology. Thanks for being here, Doc.
Thank you.
Absolutely.
Pleasure to be here.
Yeah, so you're the expert in urology, all things urology, and we're specifically talking about cancer. And there's many different cancers that may impact urology, right? So break those down for me.
Well, it's any cancer that from the kidney to the collecting system, which is the ureter and the bladder, the prostate in men, urethra, external genitalia cancers, testicular cancers are the ones that I deal with. And I'm not a cancer specialist as an expert, but I'm a general urologist and we see them all.
Gotcha. So, and so earlier in our midday newscast, we did talk about, there may be surgery options when it comes to these types of cancers.
Correct. Thankfully, in urologic cancers, a lot of them are treated surgically and curable. If you have a small kidney cancer that has not escaped from the kidney yet, the cancer or a portion of it, of the kidney, can be removed, or the whole kidney sometimes, and you're cured of that cancer. The same thing for the bladder. Bladder cancer is similar to skin cancer in that you could maybe get a skin cancer here on your face, have it cut out and be cured, but then get one on the back of your hand. So with bladder cancer, you're under frequent surveillance and often chasing recurrences, but they're not that often that they kill you.
Good, that's good news.
Prostate cancer is highly curable if caught early, and testicular cancer, as I said earlier, is possibly one of the most curable cancers that there are.
Well, and that's good news, but of course we want to prevent cancer as much as we can, and we did talk a little bit about prevention tactics, and maybe we can get into those really quickly before we get into diagnosis and treatment options. But prevention is kind of key when it comes to cancer.
Well, for the one that really comes to mind with urologic cancers and prevention is don't smoke. Smoking is highly linked to bladder cancer. And I always tell anybody who sees red blood in their urine, if you're a smoker particularly, but anybody should get that checked out. But preventing smoking is one thing that I would say for bladder cancer. And then for cancers in general, we know that they're due to chronic inflammation. So anything that sets up inflammation is not good. If you've got chronic kidney stones or chronic infections, you try to prevent those as much as possible. And I believe that the best way to do that is to eat well and live a healthy life with exercise. Yeah,
it's like that saying, let food be your medicine and your medicine be your food.
Exactly. Live healthy, be healthy.
Awesome. And so, but for the Western society, a lot of it it's kind of hard to live that way in America. So if someone is diagnosed with cancer, take me through the process. I'm sure it's different for each type of cancer.
Absolutely, just pick probably the most common that may be of interest to your viewers. For men, it would be prostate cancer. Probably that's the one that we focus on the most. It's highly curable if caught early, so I am a big fan of screening for PSA. There's been a debate in the medical community and the literature over the last 10 to 15 years really about if we should screen, when we should screen. And I always try to think of it as if it were me or one of my family members, I'm not going to listen to the national statistics on whether we should screen based on how much it's going to save society and the healthcare system. I recommend all men get a PSA checked in their 40s at some point, mid 40s. If it's great, if it's under 1, excellent. If it's under 2, good. If you're a little over 2, then you need to be watched.
Okay. So what do those numbers mean?
PSA is a blood test. It's actually a produced. PSA is prostate-specific antigen.
Okay.
It is a component of the secretions of the prostate, and it's detectable in small amounts in normal, healthy men. And in instances where the prostate has disease, whether it be infection, enlargement, or cancer, those levels can be detected at higher levels. That PSA is. So we have normal ranges, and the younger you are, the lower you want your PSA. As you get older, we typically aren't as concerned, but there still are normal ranges. 4 is a cutoff that you want to be under, kind of for all comers, all encompassing.
Yeah.
But if you're a young man, you want it to be under 2, certainly. If it's over 4, get it checked.
Yeah.
No matter what your age.
Gotcha. And so you suggest start checking around in your 40s. So let's say it's over 2 when you're in your 40s. How often should you go back?
In my practice, again, this may change based on the national guidelines, but in my practice, I recommend getting it checked once in your 40s, and if it's over 2, I would put the pieces of the puzzle together. I always say it's kind of like putting a puzzle together one piece at a time. You can't always see what the picture is,
right.
But once you get enough of the pieces together, you can tell, is it cancer or not. I would talk to you about how well you're voiding, if you're emptying your bladder well, or if you have signs of obstructive voiding. Have you had infections? Is there family history? How big is your prostate? Do we have a trend line on your PSA going back so we can see what we call the PSA velocity is, if it's changing over time? All those are pieces of the puzzle that are important, and you just put it together and try to come with a plan. If you're thinking it may be an infection, a short course of antibiotics can bring that PSA back down and everybody is happy. But if it stays elevated, then we would get into the discussion of whether you want to be on the more aggressive side and consider biopsies or MRIs or other imaging techniques to differentiate cancer from non-cancer, or if you want to watch it for a little while. And in your 40s with a PSA of 2, it's rarely imminently dangerous, but it's something that you just need to watch, and I keep a close watch on you.
Yeah, and so the PSA alone is not necessarily indicative of cancer. Okay.
Yeah, exactly, not alone. And depending on what your PSA level in your 40s, then I would recommend starting either continuing the check or starting again in your 50s sometime. Just touch base. If your PSA is always low, great. You don't have to have a PSA every year. I don't advocate for that in all men, but if it's a piece of the puzzle that is giving me an image that may not be benign, then I'd watch you closer.
Gotcha. So you are a urologist, right? This is your specialty. So, and usually to a specialist, you need a referral, correct?
Correct.
Would someone?
Depends on the insurance plan.
Oh, gotcha.
Typically, nowadays you don't. You can call my office directly in most instances and get in.
Nice.
And I believe that's true with most specialists. Maybe some of the specialty practices have that requirement, but I don't.
Cool. Yeah, well, that's good news. So, and you mentioned earlier, you're a urologist, not necessarily an oncologist, right? Which is someone who manages the cancer, but you can kind of be a part of that care team if someone is diagnosed.
Exactly.
Okay.
And for instance, with the prostate cancer, since we were talking about that one, although I started my career doing surgery for prostate cancer, my practice being a solo physician has kind of evolved to where it's just been better for me in my practice not to do surgery anymore. And I obviously don't do radiation for prostate cancer, so I kind of like to see myself as a impartial advisor. I can kind of give you the options and the risk benefits on both sides of the coin, and try to be an impartial advocate. And if you need an oncologist, which is a medical specialty that deals with cancer, that's something I can refer you to as well.
Cool. Yeah. So you're a part of someone's care team. You're like a support for them. And so, when do you suggest someone get established with a urologist? Like, when are maybe signs, symptoms, or is it great for just overall health to be established with one?
Most things in urology are noticeable. Most symptoms and signs are noticeable and concerning to patients, so they often self-refer. If you've got a kidney stone, you're going to end up seeing a urologist. If you've got blood in your urine, hopefully you don't ignore it and you're going to see a urologist. If you're getting recurrent infections, most physicians refer to a urologist. But urology is always thought of as the male specialty because of the prostate is the biggest thing that we deal with probably. But I would say, like I said, all men need to get checked out once in their 40s, and if they're having voiding symptoms, those can start even earlier. Yeah. Those can start in your 30s, and I don't recommend that you ignore it if you've got a slow stream when you're voiding, or stopping and starting, or you're noticing that you're getting up at night, or you're having to stop on the way to Dallas where you used to drive all the way without stopping. You know, those all can be signs that something's going on that you need to know about.
Gotcha. And those can kind of be subtle signs.
Very subtle,
too.
and a lot of people ignore them, particularly men. We hate going to the doctor.
Right.
So, yeah.
I wasn't going to say it, but I'm just kidding. So if you're just joining us and you have a question for Dr. Siskron, give us a call at 318-219-4569. The number is right there on your screen. And when you do call, just turn your TV all the way down so that we can hear your question. We're talking all about urologic cancers, or maybe if you have a specific urology question for our urologist here, you can give us a call. So, what kind of cancers that that we're specifically talking about, these target cancers, urologic cancers, can any of these, we've talked about the ones that are more curable, or any of these like maybe more deadly than the others, or more apt to spread than
Absolutely.
others?
Any cancer can be deadly. Most. It depends on when you catch it in the phase. It seems like kidney cancers are probably a little more dangerous than bladder and prostate, but it just depends on when you catch it. It's really, and again, like I said earlier, it's one of the things that I like about urology is that we can cure a lot of the cancers when caught early. So if you catch a small kidney cancer, particularly very small ones, we're even recommending observation these days if you're older and not having any symptoms. Bladder cancer is unique in that almost all bladder cancers are discovered before patients die, unlike a lot of cancers which are diagnosed incidentally at time of autopsy or at time of death from something else. Most bladder cancers are discovered while the patient's alive because they present with hematuria or blood in the urine, difficult symptoms with urination. Right. So we find those a lot because patients come to us or are referred to us for those problems. But the cure, I really think the rate of cure for most urologic cancers is highly dependent on how quickly you find it, and just ignoring symptoms is never good. The exception to that is like I said before, testicular cancer, which is curable almost at any stage. Lance Armstrong is a good example of that. He waited till he was coughing up blood and had metastatic lesions in his lungs before he sought treatment and was cured. So, but I don't advocate everybody do that.
Right. Yeah. And he's someone that's like a really, big advocate for health and stuff too. So even if you do live a healthy lifestyle, I guess you're not necessarily exempt.
Exactly. You're not exempt. Yeah.
Right. Which is kind of unfortunate. Yeah. You can do everything right and you can live by the book, but cancer, unfortunately, is just one of those things. If you live long enough, you might, be more at risk, or, really at any stage too. Yeah. So. So you mentioned staging. So I think a lot of times people talk about cancer stages and kind of throw that around. So if you don't mind kind of breaking that down, maybe what that looks like with urologic cancers.
Well, for every cancer has its own staging criteria, but generally when you're talking about staging, stage 1 is going to be something that's very early and usually curable with surgery or some other form of treatment, radiation or chemotherapy. Stage 2 is when it's progressed. I'll use bladder cancer as an example. Stage 2 is when it's invaded into the muscle of the bladder. An earlier stage 1 would be when it's limited to the skin lining the inside of the bladder. Stage 2 is when it's invaded into the muscle, and that becomes a more pressing issue, and you generally require surgery. Possibly removal of the bladder is the gold standard for that. Stage 3 is typically when it has invaded through the organ and or into the fat surrounding the organ. And then stage 4 is typically classified as anything that has spread to adjacent or distant organs, lymph node spread or pulmonary metastases in the lungs, things like that.
Yeah, and it's better to catch it early, as we've mentioned, so you can kind of work on that cure. So, so you mentioned taking the bladder out.
Right.
So what happens after that?
That's called a cystectomy, and 70% of bladder cancers are treatable and curable without doing that. They present in a more early stage, thankfully, and we can just go in with a scope through the bladder and scrape the cancer out. Very similar to how the dermatologist will scrape a skin cancer off or burn a skin cancer off. We can do the same thing inside the bladder. It's just a little more difficult to get to. But for those cases that either progress, which is again only 30% of cancers will progress, or those that present in later stages, which is 30%, sometimes removal of the bladder is the option. That's called a cystectomy. That's the gold standard option. And that involves removing the bladder and then rerouting the urinary system using usually a piece of bowel that is harvested and reconfigured either into a new bladder that can be connected to the urethra so you can continue to void, or it's brought up as what we call an ostomy. A lot of people have heard of colostomies, where there's also a urostomy, where you bring a small segment of isolated bowel to the surface that then drains into a bag, and you take the ureters which come from each kidney and plug it into that piece of bowel to redirect the urine out of the body.
Gotcha.
It's a big surgery.
Yeah, it sounds like it. And then the change in quality, your quality of life,
very much changes your life.
Yeah. Okay.
Although the quality of life measurements statistics show that most people are, in the end, lead a good quality of life with a urostomy.
Yeah, well, it's probably just an adjustment.
Just an adjustment.
Yeah. Okay. Well, that's very interesting. I didn't even realize that was a treatment option for that. Which it's good news that it is, maybe the minority of people that are diagnosed with bladder cancer. Okay. So kidney cancer is one that we've not really talked about. How does that usually present?
Kidney cancer nowadays is most often discovered incidentally. There's so many scans that we get for other issues. You go into the ER with abdominal pain, you get a CAT scan. You go to your GI doctor with some sort of upset issue, you get a CAT scan, or your kidney function looks a little abnormal, you get an ultrasound of your kidneys. So we're finding a lot of what we call small renal masses much earlier. In the old days, it used to be the classic triad, one of which was pain, abdominal mass, and blood in the urine, and weight loss, other bodily functions being affected once it's spread. It used to present much later, but thankfully we're finding them earlier now.
That's awesome. Through
imaging.
Okay, and so the ultrasound CAT scan. So. Is there any other symptoms, like the blood in the urine is
Kidney
common?
cancer unfortunately doesn't give a lot of symptoms, and it's kind of like prostate cancer. There's very few symptoms until it's too late. Once you're experiencing symptoms, again, it's like pancreatic cancer also is known for that. It's once you're experiencing symptoms from the cancers, it's too late. If you do see blood in the urine and happen to be lucky that the cancer was next to the collecting system and caused enough irritation to cause a little bleeding, that's good, but symptoms typically are not good when you're dealing with kidney cancers.
Right. And would this be something that someone would need to consider dialysis? Or
only if you only had one kidney or had cancers on both kidneys. There it's a lot of gray between that white and black, but if you already have kidney damage, you're a diabetic or hypertensive and have renal failure already, or borderline renal failure, and you have a small cancer, if you try to spare most of the kidney by doing what's called a partial nephrectomy, sometimes even that can take enough of the kidney away to where it puts you over the edge and you'll need dialysis. But it's not typical when we're treating kidney cancers that you require dialysis after. It's generally treatable without requiring dialysis.
Gotcha. So let's say someone is just joining us and they, maybe are having some of these symptoms that you've been mentioning. Can we go over those symptoms again, or warning signs of these urologic cancers, just so if somebody's watching at home like, oh, I've had these symptoms, what do I do now?
Right. Well, again, unfortunately there's not a lot of warning signs, but the big one I would stress again is blood in the urine. If you're having difficulty voiding, emptying your bladder with frequency, urgency, pain when voiding, things like that can indicate a bladder cancer, although those typically present with blood in the urine. Any noticeable mass, testicular cancer, all young men, pubertal age and even up until their 30s should, check in the shower, just like women are recommended to do a self-breast exam, self-testicular exam, just to make sure everything feels normal and the same. If you feel a hard spot growing, then you need to get that checked immediately. But for the other cancers, there's not a lot of external signs that we see. Okay.
And so you talk about blood in your urine, and that's like you can physically see it.
Yeah, if you physically see it. Although there is also called microscopic hematuria, which means the urinalysis test, the technician in the lab commented on seeing red blood cells in the urine, and we get a lot of referrals from other physicians for that as well.
And what would that mean? Anything or a lot of different
well, they're
things?
referred. It can mean a lot of things.
Yeah.
Kidney stones, infection, high blood pressure, and the kidneys just letting some of the red blood cells through. But the reason that they're referred to us is to rule out the big C. And so if you're referred for microscopic hematuria, we treat that often. If it's true microscopic hematuria, we treat that often just like we do gross hematuria, which means you can actually see red blood.
Okay. So, let's say someone wants to come see you. What are some of the other things? So we've been talking about urologic cancers, but maybe what are some other things that you would be able to help someone with when it comes to urology?
Well, urology is classically thought of as kidney stones management. Anything kidney stones, obstructive voiding symptoms from men makes up a large part of urologic practice. The prostate likes to grow as we get older, and it can cause obstructive or weak stream. And then that leads to irritative symptoms of frequency, urgency, getting up at night when you didn't used to, not being able to hold your urine as long, wetting your pants, when you can't get to the bathroom in time on the men's side. And then from the female side, we see a lot of overactive bladder and stress incontinence, which means you cough and sneeze and leak, or urge incontinence where you can't hold it long enough. That's more common in the female population of patients. But voiding issues, kidney stones, cancers, and then anything on the external, typically men, but external genitalia issues. Just most people think of urology and think of only that, but that's really a small portion. So if you have rashes or bumps or swellings or problems, erectile dysfunction is a big part of urology.
So with the incontinence that you just mentioned, or trouble voiding, what are some options for that? Does someone, can you help them, whether that's through, is that a surgery option, or is there other kind of options?
Again, it's totally dependent on male, female, number one, and then what the symptoms are. So if we take females, are you leaking when you're coughing, sneezing, and swinging your tennis racket? That's going to be stress incontinence. And that can be helped with physical therapy, pelvic floor physical therapy to tighten things, and some behavioral modifications, but often that leads down the surgical road more. And it's highly dependent on a lot of factors as well. Have you had children before? Do you still have your uterus? Have you had a hysterectomy? Do you have any prolapse? All those things factor in.
So does it increase if you do have a hysterectomy?
Typically, statistically, the more children that you've had, and hysterectomy can change the anatomy and the pelvic floor structure enough to where that is going to put you at a higher risk for incontinence. If you are having incontinence because you just can't hold it and you're getting home and you're rushing to put your key in the door and thinking you're going to wet your pants, that's more of an urgency incontinence, and those are often helped more with medications and other techniques. Physical therapy can also be used there. There's also nerve stimulation techniques that can be used.
Interesting.
For that.
Cool. Well, we have John on the line. John, thanks for joining us, and what's your question?
I have a question at the enlarged prostate. I understand there's a procedure called the Tulsa procedure, and I was just wondering if there's anybody here doing the Tulsa.
Can you repeat that procedure one more time? I'm going to have to communicate that with our doctor.
Is there anybody that can do the Tulsa
procedure
operation here? I know there's several different ways of.
I think if he's just asking in general.
Tulsa procedure is a relatively new technology. It uses high-frequency ultrasound. We don't have it in Shreveport, but I've referred some patients to Dallas for it. And it uses an ultrasound probe that is placed through the urethra and positioned inside the prostate. And then it can be directed, the high-frequency ultrasound energy can be directed to areas of the prostate to treat cancer. It's not a gold standard treatment for cancer, and it's probably not even formally approved yet for cancer, but for small lesions that can be identified on an MRI, that is an option that some men are choosing now. It's good for also benign disease as well, for just treating enlargement of the gland.
Gotcha. Well, thanks, John, for your question. Was that helpful?
Thank you. Yeah,
okay.
Thank you.
Thanks. Yeah. So you would refer to for someone in Dallas.
Yeah.
Okay.
The Tulsa is currently not in Shreveport. There's also some ultrasound therapies that are available in Shreveport that are done through transrectal probes, where the probe is in the rectum and goes through the rectal wall to get into the prostate. There are some urologists in Shreveport doing that as well.
Gotcha.
That's another option for ultrasound.
Cool. Okay. So let's say someone's just joining us. I know we mentioned this earlier, but let's say someone's just joining us and they have a question about, like, how do I get in to see you? You know, what's the best way? I think a lot of people think that they need a referral from a doctor, but that's not necessarily true.
My office, I accept patients. You just call my office number and we'll work you in.
Okay. Do you mind sharing that number with us?
212-8899.
Oh, that's pretty easy. 212-8899. I can even remember that. Okay. So they can just give you a call, and how soon could they get in?
Well, it's getting increasingly busy in the last few years. I think all healthcare things are getting much busier in modern society, but I'm booked out probably 4 to 6 weeks right now for new patient appointments.
All right, that's not too bad though.
So, but if it's an emergency, obviously we can try to squeeze you in sooner. But,
okay, and you accept some services would be covered by insurance, I'm assuming?
Right. I accept almost all insurances through Willis Knighton.
Okay, and this is Signature Urology with Willis Knighton. Where can we find you?
My office is on Greenwood Road at the Willis Knighton North, or the main campus, 2551 Greenwood Road. All right,
and 212-8899.
Right.
Do you have a Facebook page or a website that if they wanted to know a little bit more?
There is a Signature Urology Willis Knighton website, and you can book appointments through there as well.
Okay, and again, you know, you're a urologist. We talked a lot about cancer today, but you would be a part of that maybe even like diagnosis process, or maybe prevention process, as we mentioned, the PSA. You would be able to do that. Just real quick, remind us what the PSA is and how, if somebody was interested.
The PSA is prostate-specific antigen, and is the screening test that we use for finding prostate cancer and other problems with the prostate. Okay. And I advocate that all men get it at some point in their 40s, and then depending on what it is, we can talk about when you need it again.
Okay. Awesome. So yeah, if you're interested in doing that test, give them a call. They'll get you in and make sure we're preventing our cancer risk. That's a big part of I think healthcare nowadays is really we're really pushing that prevention.
Right.
So yeah.
And I also, in my practice, some people are receptive to it and some aren't, but I like to talk about diet and proper diet and exercise, and how being healthy can prevent a lot of the problems that I see.
That's really important.
80% of the things that I see in my office can be prevented with better lifestyle.
All right. Thanks for joining us.